This is a Fox News Radio healthcare checkup. What's working, what's failing, and what can be done to make it better? Now here's Fox's Jessica Rosenthal.
Are you sick of hearing politicians argue about your healthcare?
Obamacare has failed, and Obamacare must go.
Democrats are not going to continue to try and amend the House plan that is already dead.
Obamacare is predicated on force and coercion.
Their vote was irresponsible. It was reckless. It was cruel. It was immoral.
Repealing and replacing Obamacare. We better get that done, fellas.
Well, I promise you, in the next hour, you won't hear another politician, but you will hear a lot about healthcare from the men and women on the front lines. Doctors, insurance providers, attorneys, patient advocates, and patients like you. The Affordable Care Act, or Obamacare, was on life support, on the verge of repeal in Congress, but the Senate fell one vote short of an effort to repeal many provisions of the bill. So, at least for the moment, Obamacare is still the law of the land. So what does that mean? Well, doctors tell us our healthcare system doesn't really work, and didn't before the Affordable Care Act. Patients feel like they're looked at as a dollar amount, and everyone we talk to agrees the system is a beast. We begin with our patients, the end users of healthcare, and you'll hear a mix of emotions, burdened by cost, even with insurance, fear over the future of healthcare, frustration over a lack of communication, but also gratitude that they're still alive. I got 8 people together with varying degrees of chronic illness and conditions to talk about how healthcare works for them. They've experienced different coverage over the years, private, COBRA, 2 had experiences with Medicaid, and 2 of the men went without insurance for years. Among our patients is Alana Kramer. She's experienced multiple brain injuries.
We still don't have $1 million later a clear understanding of how my brain are creating the symptoms that I live with every day.
She says her mother sank all of her retirement money into her care, while she's had 12 years of pain and a condition called dysautonomia, a catch-all term for a malfunctioning nervous system, the thing that keeps you blinking, swallowing, breathing. As frustrating as her condition is, she's most overwhelmed at times by the lack of communication among her doctors. Kramer says she recently chose a cardiologist at the hospital specifically where her other doctors worked so they could communicate.
So I was so shocked to be at Cedars-Sinai, which, is a very reputable hospital, to learn that despite the fact that I have a number of doctors at that particular facility, even in their database system and their portal system that is designed to communicate with different doctors, they don't have that set up. And I was actually at the cardiologist for 3 hours because we had to wait for me personally to run to another doctor's office to personally ask the receptionist to print the paperwork, the blood test results that we needed, to then me personally bring back to the doctor's office. So,
and you probably got sicker just doing that.
No question. I've been sleeping for 2 days as a result.
Others at the table nodded in empathy, including Shana Sorrentino. She says she's been sick off and on for over a decade. And like Kramer, doctors still aren't sure what's really wrong with her. All she knows is tremendous pain that comes and goes. A few months ago, she couldn't even move her legs. She says communication mishaps occur frequently and that an electronic record system is supposed to be utilized.
All the information has populated in incorrectly. And then when you're hospitalized, you let them know this, okay? And they make notes, but for some reason it doesn't get changed. And then they keep trying to feed you the wrong drugs.
Speaking of drugs, nearly everyone had issues with medication. How much is covered? The cost. Dave Leibowitz has psoriatic arthritis, degenerative disc disease, and a bone spur in his neck that causes nerve pain.
I could have flown to Germany, done the surgery, and spent something like 6 weeks in a rehab hospital over there and come back for about $50,000. My hospital time alone in the U.S. was billed at over $200,000. Why not let me do that and save the insurance company money and work with a doctor of my choosing in Germany that's been doing it for 15 years? So the more choices that we're given, the better the market will function naturally. And frankly, the healthier we'll be.
Why you weren't talking to the Congress?
I would be happy to.
Being moved through the system quickly, getting kicked out of the hospital, or hearing you don't need certain treatments anymore also gets a lot of nods. Mark Spelber was experiencing back issues. Pain and soreness permeated the left side of his body. Turned out a cyst was pressing on some nerves. He had back surgery and needed months of physical therapy.
I went to a bunch of in-network physical therapists that I would characterize as mills, where they're seeing 4 or 5 people at a time because they accept insurance, and the net kind of revenue to them is so small that in order to keep the practice open and have this huge billing department that handles all this insurance stuff, they've got to see 4 or 5 people at a time. They're mainly focused on doing some massage. They're not necessarily customizing your treatment or really talking to you about what's going on.
They worry about the future. What kind of insurance will exist? Will they have it? Mia Shakowitz was paralyzed in the mid-90s when a blood vessel in her spinal cord ruptured. She uses a wheelchair but is relatively healthy now. She says she was on Cobra insurance for a bit while she switched jobs. Cobra's a sort of gap health insurance plan, more expensive when you're not working. But she got dropped when her former employer changed health plans. She got on an HMO plan under the ACA exchanges as she was beginning to experience stomach pains.
And I was appalled at the difference between just the way people are treated on the different plans even. Like going through this HMO where I could not get a doctor's appointment in time, and I was getting worse and worse and worse. And when I ended up going to the emergency room one night because my body had completely shut down.
She says preventive care at a doctor's office probably could have saved her that ER visit and a lot of money. Falling through the cracks, finding out you didn't have the kind of insurance you thought you had, is another big fear. Shana Sorrentino says she got dropped from a doctor because of miscommunication she didn't even know had occurred.
I loathe going to my mailbox. Not for any other bills, but my healthcare bills. Because what if it's that one thing that you got the prior auth for, but for some reason, it was still denied. It was still denied. And then you have to fight it. You have to go through so many people just to reach somebody in America, to speak to them. I'm being honest, to speak to a supervisor in America, and you have to go through an entire train.
Drew and Jason Leach say this is all too much for them. They just won't deal with it. Drew has had healthcare complications. Jason has a moderate shoulder injury.
I haven't done anything about it because all of these stories about billing nightmares and people not wanting to take responsibility, those are the things I'm worried about. I don't have the extra income.
I mean, we seem to be working fine, but I don't know what's going on. I'd love to send both of us for blood work, just to make sure that we're good.
Karen Leventhal struggled with chronic fatigue syndrome for years before she got help. Her frustration now lies with research. Are doctors really up to date, learning about the latest cures in their field?
And yet I'm seeing articles come out, frequently about, we just discovered something new about chronic fatigue syndrome, and, we don't know what it is yet. I'm like, I've been basically well treated for 8 years, so why do they not know about these treatments? And I'm not sure why we as patients have to do this and go on Google. Like, can't the doctors go on Google? I don't understand why there isn't a system for understanding what's working with other people.
They're not sure what a solution is. Kramer says it seems like doctors are creating their own solutions and refusing insurance.
I had a cardiologist that charges $5,000 a year just for the ability to walk into his office without anything being done.
And while they're not sure most people could afford that and do need insurance, they agree with Spelber. The system doesn't work too well.
I have an economics degree. I'm an MBA. I'm very much a free market, business-minded person. But there was definitely points where I'm like, this just doesn't seem like it should be about profits or a business. Like there has to be more of a empathetic approach.
While a couple of the patients with whom we spoke have dealt with Medicaid, Joe, who didn't want to give his full name, is a conservator for a woman who was using California's version of Medicaid for a while, until she turned 65 and got on Medicare. Medicaid's for lower income folks, Medicare's for the older and disabled.
The problem with the Medicaid was a lot of doctors won't even see you. They're not paid enough, basically, to make it worth their while. Now, it's been a big change. As soon as she hit that 65 mark, even though she might not have the most elite kind of supplemental insurance, she's getting a completely different level of coverage.
Now she's on both. And what Joe said about doctors not making enough money is a large part of what's next on our Fox News Radio Healthcare Checkup. We hear from the doctors, and many of them have some harsh words about a bureaucratic system they say places profits above people. This is the Fox News Radio Healthcare Checkup. I'm Jessica Rosenthal. Doctors are frustrated with pretty much everyone in the healthcare system. Hospital administrators, health insurance companies, and patients.
We have the finest healthcare system from the standpoint of technology, expertise, but the way that expertise and technology is distributed among the population is very broken.
It's hard to say, but what we currently have is not working.
It's a fairly broken system.
Dr. Alan Halpern works as an emergency room physician at 3 hospitals in California and in New Mexico. He says the healthcare system tries to give everything to everyone, and it just can't.
People badmouthed a lot of the efforts to do healthcare reform in the past, saying we don't want death panels. We don't want groups of people making decisions that are going to say some people are going to be allowed to die. Well, unfortunately, as painful as it is for everyone to hear this, I will tell you that we will not be able to resolve our healthcare system issues if we don't agree to ration care to some extent. We have to make decisions about how to use the limited resources that we have.
Dr. Robert Sorrentino in Los Angeles, who after years in emergency medicine became a healthcare executive, says rationed care may not be the way to go. But he agrees with Halpern some changes could save money.
An example of this is a patient comes in with knee pain. Many physicians will rush off and get an MRI scan of the knee, which costs a couple $1,000s. They won't even have done a proper examination of the knee, nor will they have gotten plain film x-rays to look at for things like osteoarthritis, arthritis of old age, or whether there's a hidden fracture there or some other disease that they could pick up on plain film x-rays.
Halpern says the problem is some patients insist on that MRI, and a lot of these patients are getting care for free. If someone shows up at the ER, they must be treated. That's because of a law passed by Congress in the mid-'80s.
If the patient says, I have no money, that's too bad for the hospital and for the physician. The care has been provided. They walk away.
So that free care, combined with low reimbursement rates for those with Medicaid, leaves hospitals making up the difference and then some.
So what do hospitals do in order to recoup the money they've lost by providing that care? They jack up their charges for everything they charge to the people who do pay. It's cost shifting.
A bill for someone with private health insurance may see the charge for a Band-Aid costing $7 and ibuprofen for $15. One doctor I spoke to didn't want to use his real name, so I'll call him Dr. Smith. He says he makes less and less and less in reimbursement every year.
Basically, Medicare sets the bar of how much a service is worth that we perform. And then the private insurers, if you accept their insurance, usually pay you some percent of Medicare, and that's how we get paid. And so far, every year that I've been in practice, Medicare says that each thing that I do is worth less than it was the year before. So the only way to continue to make the same amount of money, because the overhead continues to go up, is to do more work. So we now work 12 to 13 hours a day on average.
He brought actual medical bills to our interview to show me just how much he gets paid, including for surgeries and follow-ups.
Here's a lady with a significant problem, bleeding, emergency room visit, discharge planning, everything all told, including emergency room visit, surgery, post-procedure, everything added together, $597.61 because she has Medicare with a good secondary, relatively wealthy patient.
Let me ask you, if you treated that woman 10, 15 years ago, what do you think you would have gotten paid?
Maybe $1,000.
Dr. Smith finds this all frustrating. He accepts Medicare, as do most doctors, but he and Dr. Halpern note far fewer doctors accept Medicaid, at least in California.
In California, we call it Medi-Cal. And from an emergency physician or any physician's perspective, when someone tells you they're covered by Medi-Cal, although the patient thinks now they have insurance, from the provider's perspective, the physician, the hospital, it's as if you're giving away the care for free.
Because after reimbursement, you add in your malpractice insurance and the cost for a billing company, and you're basically at zero. Dr. Sorrentino, the emergency doctor who became a healthcare executive, explains how a lot of healthcare decisions are made by hospitals and insurance companies.
Each of the companies has a different set of medical guidelines that they use. But there are standardized guidelines. Milliman Care Guidelines, now it's called MCG, is one national set of guidelines that many companies turn to for a factual, evidence-based decision-making process. And so what they try to do, in all fairness to them, is try to identify those treatments that are going to be effective for patients, but also cost effective.
He says insurance companies and the healthcare system in general is now moving toward a value rather than a volume-based model. Dr. Smith says he's stopped taking a lot of insurance, including any Obamacare plans.
So most of my insurance premium that I'm paying every year is just going to fund insurance companies, their overhead, I know how much insurance company executives make. I know how much even mid-level management makes because I have patients who are headhunters and they told me. And so basically, the reality is what we should have is there should be no insurance. You should be on your own to pay the doctor. There's a patient and there's a doctor.
Then he says taxes should go to pay for catastrophic coverage after someone spent a certain amount on their health care. Dr. Halpern would like to see sort of the opposite, a French model. Taxes going to pay for basic levels of care, and if you want more coverage, you pay for it yourself. But they both agree insurance companies are the problem.
Right now, they're trying to solve it by looking for ways to continue the insurance system, which puts huge profits into the insurance companies and diverts a large amount of the total money available for healthcare to provide profit to an agency that doesn't do any healthcare. The insurance company doesn't work with me in the emergency department at 2 a.m. taking care of somebody vomiting up blood. But they're taking a large amount of the money that is available in the healthcare system for me to take care of that person. So until that money gets redistributed to provide the care to people and not profit, that system isn't going to get better. But even with that redistribution, there isn't enough money to give everybody everything.
Mitch Leventhal in Cleveland, Ohio is a retired physician who also owned urgent care facilities. He disagrees that insurance companies are the problem.
If you believe in the free market system, then they're very necessary because they spread out risk. They end up spreading the risk over many, many people so that no one person gets dinged for a $500,000 bill.
He says a lot of the problem is what Dr. Halpern said earlier, patient demands.
If you really want to know the people who are responsible for the high cost of medical care, look in the mirror. I mean, I know people don't want to say that, but that's a good portion of it. That's what people in this country demand, the best. And it doesn't make a difference what the cost is. Well, if you tell that to an insurance company, if you tell that to a seller, I guess in some respects what physicians are and hospitals are, they say, well, that's not, if cost is no object, I'll give you everything you want.
Now, Dr. Sorrentino says more money should go to primary care doctors, the first level of care before conditions get worse and more expensive. Dr. Manish Saha in upstate New York is a primary care doctor, and he says, yes, please. He gives an example. He says if he has a male diabetic patient who needs his blood sugar managed, but he's also depressed, has tingling in his legs or other issues, Saha has to handle all of that. But
if I take care of that patient and, I talk to him and about the depression and how to better his sugars, different lifestyle interventions he can make. But I didn't ask him about, did he go see the eye doctor? Then I get a letter from the insurance company saying, your patient hasn't gone to see the eye doctor yet. And that is, we're going to ding you. We're going to take away some money because you haven't provided optimal care.
He says they're already trying to handle as many patients as they can, not spending enough time with each of them, not being reimbursed enough, but short of driving that patient personally to the eye doctor, he can't do much else. Up next, we hear from insurance industry executives and those who fight them as our healthcare checkup continues on Fox News Radio. Welcome back to our Fox News Radio healthcare checkup. I'm Jessica Rosenthal. So how much do you spend on your healthcare each year? On average, the U.S. spends more on healthcare per person than any other industrialized country, between $9,000 and $10,000. Switzerland comes in second with $6,900. Canada and France spend around $4,500 per person. That's according to the OECD, the Organization for Economic Cooperation and Development. And at the same time, there's evidence we do not experience greater health outcomes from all that spending. A lot of that money is going to insurance companies. According to the Centers for Medicare and Medicaid Services, private health insurance spending grew to just over $1 trillion in 2015. Just under half of all Americans have private insurance through their employer, an additional 7% purchase from an insurance company on their own.
We really don't refer to ourselves as a health insurance company at all. We refer to ourselves as a health services
company.
Gene Rapisardi with Cigna Health was one of 2 insurance companies that agreed to talk to me. He and Craig Hankins with United Healthcare acknowledge health insurance companies are in business to make a profit, and they do. But I asked Hankins what he would tell patients and doctors who think medical insurance should be not-for-profit.
It's the reality that we have with the way in which the American healthcare system is set up. I mean, insurance companies are not the only for-profit entities.
United and Cigna were largely vague about how decisions get made, how claims are denied, so we caught up with attorneys who sue these companies on behalf of patients, like attorney David Lilienstein.
In the Affordable Care Act, insurance companies are mandated to pay out a certain amount. It could be 80%, it could be 85%, depending on the type of plan, to pay out a certain percentage of all the revenue that comes in, the premium dollars that come in, to claims. They want to make sure it's not going to go 1 penny over that amount. And so there are very sophisticated forms and managers of managers who are there to make sure the companies don't pay out too much.
He recalled one case he was involved in when he came across evidence from a claims manager's performance review.
The claims rep said, hey, look at all these claims I've denied. Look at all this money I've saved the company. Of course I deserve a bonus. Of course I deserve a promotion.
He and attorney Scott Glovsky agree they are seeing more denials, in part because when the Affordable Care Act passed, more patients got health insurance. More people covered equals more claims filed.
The executives at large insurance companies and the CEOs have incentives to make money now. I mean, that's their job, is to make money now for their company, not for 5 years from now or 10 years from now. And they're often incentivized to do that. So one way to do that is to target expensive treatments and expensive medications and find ways not to provide those.
But according to Hankins with United, there's a prearranged agreement between them and healthcare providers, like doctors and hospitals, about what gets covered.
There is a process to it. It starts by following the contracts that we've set up, both with whether you're covered and what we deem as covered under the contract, all of which, especially for our commercial business, but our government business as well, that's all filed and very regulated.
Rapisardi with Cigna said they collaborate on contracts with their medical providers in different geographical locations.
And therefore, it's not one side dictating to the other. It's everyone collaborating on what gets covered, how it gets covered, how it's delivered, how it's accessed.
According to the attorneys, insurance companies make decisions using statistics. Earlier, Dr. Sorrentino referenced one set of guidelines commonly used, the Milliman Care Guidelines. The guidelines website explains they review thousands of medical references and citations to help them offer different stats on medical care. They say this provides evidence to help make informed decisions about how to cover what and to avoid under or over use of medical resources. Lilienstein hasn't been impressed.
There are a lot of different guidelines. We find the Milliman guidelines can be particularly egregious. I think what you're also looking at is who is reviewing these claims. Sometimes you'll have nurse practitioners reviewing a claim. Even when you have doctors, do you necessarily have a doctor with the right board certification, someone who's in the right area of medicine to review a particular claim?
Attorney Scott Glovsky agrees.
When you look behind a lot of the statistics and a lot of the guidelines, often there's insurance companies, related to developing the guidelines.
But insurance companies, especially Cigna, argue doctors participate in the negotiations to determine what gets covered. Now, health insurance companies also get money in some cases from Medicare and Medicaid, government-funded health programs. If you're over 65, you probably know about Medicare. Medicaid is for lower-income people and families. It's jointly run by the federal and state governments. According to the Kaiser Family Foundation statistics from 2015, 20% of Americans were on Medicaid, 14% on Medicare. Judith Solomon is with the left-leaning group Center for Budget on Policy and Priorities.
Medicare is a social insurance program in the sense that it's based on having worked and qualifying for it, but it has limits. Medicare provides very limited coverage for long-term services and supports.
Some Medicare and Medicaid plans are actually managed by insurance companies and work much in the same way as they do with private insurance clients. But Solomon explains some Medicaid patients are involved in what's called a fee-for-service program.
You see a provider who's participating in Medicaid, and then that provider submits a bill to the state, which pays it.
According to the Centers for Medicare and Medicaid Services, in 2015, Medicare spending grew to $646 billion. Medicaid spending grew to $545 billion. Together, they total 37% of total health expenditures. While some doctors do complain about Medicaid reimbursement in some states, the Kaiser Family Foundation says just under 70% of doctors nationwide accept it. 80% accept Medicare. Now, on to the meds. Drug prices are higher in this country than in others. According to the International Federation of Health Plans, the cancer drug Gleevec, for example, ranged from just under $1,000 in New Zealand to over $6,000 in the U.S. The depression drug Cymbalta is less than $100 in Switzerland, Spain, the Netherlands, and in England, but nearly double here in the U.S. Aaron Kesselheim, associate professor of medicine at Brigham Women's Hospital at the Harvard Medical School, studied drug prices in depth.
Drug prices are what they are in the U.S. because we allow pharmaceutical manufacturers to set prices at whatever the market will bear. At the same time, there are a number of different aspects of the marketplace, including laws and the inefficient market itself, that make it so that it makes it very hard for the payers to effectively negotiate with pharmaceutical manufacturers who hold a monopoly.
The Center for Responsive Politics says in the past 20 years, the pharmaceutical industry spent more on lobbying than any other industry. Much of it's done by the Pharmaceutical Research and Manufacturers of America, or PhRMA. PhRMA's Vice President of Public Affairs, Priscilla Vanderveer, says while they are concerned about patients struggling with high drug costs, the media often reports list prices, which don't accurately reflect, she says, the real cost after insurance or government coverage brings that cost down.
There's a very complicated drug supply chain, and throughout that system, you have a whole series of middlemen, from pharmacy benefit managers who negotiate contracts on behalf of insurance companies to pay for prescription drugs. You have insurers themselves, drug distributors and wholesalers, pharmacies. And what we know is that, a third of all spending on medicines is actually going to other people in the supply chain.
Politicians, including Democratic presidential candidate Bernie Sanders and Republican President Donald Trump, have attributed some of the high cost to the inability of most government agencies to negotiate drug prices like other countries do. Now, the VA gets a sizable discount for veterans, and they can negotiate. But for Medicare Part D, for example, direct negotiations aren't allowed. PhRMA's Vanderveer argues negotiations over price do occur.
Our companies negotiate with those pharmacy benefit managers and insurers, and yes, those negotiations are private, but the whole point is to bring the cost down. What's happening is that those insurance companies and those pharmacy benefit managers are getting bigger and bigger discounts and rebates, and they're not being passed on.
In his study, though, Kesselheim found another aspect of high drug prices is a pharmaceutical company's effort to keep their patents for as long as possible.
One thing that pharmaceutical companies do is a process called life cycle management, where they take steps to try to delay generic entry as long as they can by obtaining other patents or engaging in other kinds of lawsuits.
In some cases, changing something small about the drug and arguing it is significant enough to extend their control. But Vanderveer says these smaller changes, or incremental innovations as they call them, are often not so small. And in some cases, it makes a drug more effective, longer lasting, fewer side effects.
We hear a lot about this in the diabetes market, and people say, oh, insulin hasn't changed since 1935, and you hear comments like that. But the reality is, with certain types of insulin that are available today, make a huge difference to patients.
That innovation often comes from the much talked about R&D, research and development. Kesselheim says his research shows drug companies invest just 10 to 20% of revenue in R&D, even less than that on new products as opposed to managing existing ones. Vanderveer says a 10% investment compared to global sales is the minimum amount required in order to be a member of their organization. She says just 1 in 10 products that gets into clinical testing actually ever gets to the market, and that it's even less than that when it comes to drugs for more complicated diseases like Alzheimer's, Parkinson's, and ALS. Up next, some folks who can help you, patient advocates. They share their secrets about how to make it through the maze of healthcare when our healthcare checkup continues on Fox News Radio. Continuing now with our Fox News Radio healthcare checkup, I'm Jessica Rosenthal. So you're sick, or maybe someone you love is dealing with a serious medical problem. You're dealing with doctors, hospitals, labs, insurance companies, each with their own interests. But who's looking out for you other than you? Well, they call themselves patient advocates or healthcare navigators, and they play detective, lawyer, and companion all at the same time. Martine Bruce is an advocate and a certified mediator. She remembers the moment when she moved from billing manager for oncologists to helping patients navigate healthcare.
Actually, it was this one older lady who looked at me and said to me, I cannot afford what you're telling me, but I owe you, so I will cancel the treatment, just let me die. And that was on a Friday night, and I couldn't sleep the whole weekend.
That Monday, she started implementing a plan to advocate for patients from the doctor's office before she started doing it full time. And she has stories. Recalling a man with an $89,000 bill, a woman with a $250,000 bill. Her job? To get that cost down by fighting hospitals and insurance companies, but also educating the patient. In one case, a patient with breast cancer had a mastectomy, but the next day, her surgeon noticed some tissue was dying and ordered her to a bariatric chamber at UCLA.
The bill comes up to about almost $30,000. The insurance denies, stating that UCLA is not contracted within that network and that she had a choice to go to other facilities that were in network. I filed an appeal explaining these were emergency conditions, and the doctor send her to the nearest facility that could accommodate or who could render the service. And under federal law, any emergency services must be paid at the higher in-network rate. I lost that appeal, so I went straight to the state of California and explained again that circumstances were an emergency, even though she did not go to the emergency room. She went to a surgeon. And I had obtained a copy of a request from the surgeon to UCLA where it showed this is an emergency, get her in today. And with that, I won the case.
Patients have the right to appeal an insurance company's denial and have it reviewed by a third party. If your state doesn't have an external review process, you can go through the federal government's Department of Health and Human Services. Some cases are more simple. Lisa Berry Blackstock does similar advocacy work. She recalls an elderly patient with cancer who was rushed to an LA hospital. Her husband had died a year earlier, and his health coverage no longer covered her. She hadn't gotten her own insurance plan. Blackstock got a call from the woman's relative in the Midwest
saying, my aunt's carekeeper has already written $45,000 in checks to this hospital. We still don't know what's wrong. And, at this rate, even though my aunt isn't poor, she can be out $400,000 pretty soon. Is this legal? And I said, no, it's not legal.
She says they cannot demand money up front without an itemized bill. So she was hired and went to the hospital.
They wanted me there when the woman from the financial aid office would appear, because that woman would consistently come by between 10 and 11 every morning. And when the woman from the financial aid office came by and asked for her $15,000, I interjected and I said, excuse me, we'll be very happy to give you a check, but we just need an itemized invoice of what it is that we're paying for. And we never saw the woman again.
She says some hospitals know to look for the wealthier patient zip codes and take advantage. Another client sold her house to pay her medical bills. Blackstock was hired after the fact.
And it was only through her nephew she found out after that had happened, and after the heartache of losing her home, to pay a six-figure obscene bill to a hospital. Did she and her nephew find out that every single one of those charges could have been negotiated?
That's one of the key points Blackstock really wants you to know. Negotiate your bill. She says you can use healthcarebluebook.com to help you. It's like the Kelly Blue Book for your car, except for medical rates. In one case, Martine Bruce asked what the cash price was for a particular procedure. In other words, what someone would pay if they didn't have insurance, and it was nearly half price. She recommends you ask for that when you get your bill for out-of-pocket expenses. Now, Prissy Cohen, who does similar advocacy work, says one of her cases got intense. She had a 90-year-old client who bought travel insurance and then went to Spain. But the woman had a heart attack and gastrointestinal bleeding while there. She was staying in a hospital in Spain, but she wanted to come home. The insurance company in the U.S. wanted to send her home on a commercial flight, but Cohen says she was simply too sick.
I was able to get on the phone with someone from the FAA and find out that certain regulations said that actually a commercial transportation carrier could be an air ambulance. and that it falls under the regulations. And so I was able to fight for that.
And when they tried to make her client pay for about a quarter of the cost, she fought that too, citing the insurance company's very own policy. Now, all three advocates agreed Medicare probably provides the best coverage, though Blackstock worries even that's narrowing. And while each agreed that this for-profit system creates a lot of the problems that they see, some like Blackstock were more adamant.
I talk to a lot of doctors off the record who tell me, if my administrator tells me one more time that I'm spending too much money on this patient and the hospital isn't being reimbursed enough, I'm going to, have a black check against my name. That I've heard in all kinds of variations.
But they don't necessarily think eliminating insurance is the way to go. A full concierge model where doctors just demand payment directly from patients.
Unfortunately, I see it as a trend where if you have the funds, then you can pay cash. You get access that is immediate. You get basically the gold star standard. You get the VIP treatment. That's really nice, but most people in this country cannot afford it. So we still need insurance companies. The question now is this system of, again, for-profit, is that something that we as a society want to continue with?
For now, their advice, Cohen says, know your policy.
Where do you buy your insurance? There are brokers, there are agents. If you're getting it through an agent, make them explain every single line.
If you see evidence on an insurance company's website that a doctor you want to see is in network, print that out, just in case things haven't been updated on the website, but that doctor is no longer in network.
You have the right to an itemized bill that you can examine. Was every charge billed to you correct in the sense, was the service actually rendered to you?
Bruce says it's your job to fight, and for those who are just too sick to fight for themselves, well, that's what these advocates say they're there for. There's no doubt people who are alive today are the healthiest in history. We live longer. The number of years of peak productivity is higher. Ailments that were once death sentences can become manageable conditions. Still, in the past hour, we heard from many who feel our system of healthcare is sick. And we heard plenty of reasons. The sky-high costs, bureaucracy, insurance companies, hospitals. Of course, the political bickering in Washington over it isn't giving anyone a whole lot of confidence. But if the medical community can make our lives better with cures and treatments for diseases that would have killed us a generation or two ago, then here's to hoping those who manage it can cure how much of it's delivered. For all of us at Fox News Radio, I'm Jessica Rosenthal. Thanks for listening.